Honorable Chairpersons, London audience, very good afternoon. And this is my, basically this is not my case. This is the complex PCI with the on-site surgical backup. In contrast to this subject, I will show a case and for better discussion. Mrs. X, 35 years old, diabetic, non-hypertensive, and she has a history of non-STMI, stable angina, CCS class 3, echoanterior hyperkinesia, EFN 45%, and her synthesis score after angiogram, her synthesis score was 16. This is the coronary angiogram, significant left main disease. After CAG, significant left main disease, might plaque in left main ostium, LAD ostium, and RCA is quite normal, and LCX quite normal. Might be it's a codominant. And what is after CAG, we counsel her for coronary bypass surgery and discharge her from hospital. 1 month later, she came again with chest pain and she denied to do CABG. And she has no capability to do CABG and don't want to come Dhaka. After decision, we decided to do PCI, guide 6 friends, gel 3.5, 6 friends, Version blue and Ranthro, and pedalation with balloon 1.5, 12, and 2.5 to 12. And we put a stent 3.5 into 16, crossover the LAD, left main to LAD, and push dilate with 4 into 8 quantum apex NC balloon. Sorry, this slide is not moving. This is the final result. And here is my question. This case should be done outside Dhaka or there is no on-site surgical backup. And what the recommendation regarding this type of complex cases where there is no surgical backup or adequate instrument in the cath lab. Some old recommendation. Now this is the latest recommendation from SKY expert consensus statement. What they say regarding this type of cases. They say elective PCI in setting without on-site surgery has increase in volume and complexity. Simple lesion recommendation. In addition, PCI is now being performed outside the hospital setting. Several new studies in the United States and abroad have demonstrated that PCI performed and non-surgical center have very low rate of complication and similar outcome to PCI performed at surgical centers. Despite increase in age comorbidity and lesion complexity, the rate of pre-procedural complication has remained constant or declined with rate of emergency surgery as low as 0.1%. Regarding left main PCI, complex PCI including unprotected left main is being performed at some non-surgical center with no increase in MACE or emergency CABG surgery compared with PCI at surgical center. Other complex, there have no comparative study in other complex PCI subgroups such as CTO and atherectomy. They proposed an algorithm regarding PCI. There is no on-site surgery. Patient for play. This algorithm for only for elective patient. not for acute coronary patient. If there is last remaining vessel, retrograde CTO, and patient is surgical candidate, this type of patient should be done with a surgical backup. Decreased left ventricular ejection fraction, planned atherectomy, unprotected left vein, CTO, a degenerative vein graft may be done without surgical backup, but PCI at hospital without, but with left ventricular device, ECMO, calcium modification device, high PCI volume center can do this type of PCI. And other cases, high transfusion rate, high baseline respiratory rate, AKI, high risk of AKI, PCI should be can be done in without surgery, but multidisciplinary hospital should be done. And other type of PCI can be done without surgical backup. And some predictor of emergency surgery may develop after PCI. Patient, acutely presented patient, left ventricular failure, cardiogenic shock, female patient, and patient with total occlusion, and atrocity and severe calcification. And equipment should be available. Equipment should be available in cath lab where there is no on-site surgery. And operator should be high volume operator should be done surgery and PCI without on-site surgery. This is the operator experience. Staff should be trained in each cath lab. And finally,
Doctor,
patient.
your time is up. Your time is up.